안녕하십니까, everyone. Thank you for kind introduction, Jay Song-Hae and Professor Hasahara. I'm very happy to be here again and meet face-to-face all my friends. I'm going to present interventionist opinion on the issue of management of the after repair of tetralogy flow. I have no disclosure. As you are all aware, clinical use of TBVI began in the early 2000 with the prototype of the melody valve by Bonhoeffer and colleagues, and various valves, including sapien and pulsar valves, have been developed. About 25 of these post-operative patients with tetralogy flow and related heart diseases are eligible for balloon expandable TBVI with a conduit or bioprosthetic valves, and about 75 are eligible for self-expanding TBVI with an RVOT derived from autologous tissue. Sapien 3 was approved in Japan in September 2020. In our early stage, this device is regulated to be implanted inside a surgical bioprosthetic valve or a conduit graft. The target criteria are moderate or severe pulmonary regurgitation or pulmonary stenosis with a median gradient of 35 millimeter or more. In addition, the criteria includes patients are considered to be at very high risk for open heart surgery, such as history of multiple open chest, RVEF less than 45, LVEF less than 45, and RVESV index more than 95, and age older than 45. The Harmony valve was approved in Japan in 2021. It targets RVOT with the expanded autologous tissue, and the criteria are broader than those of the Sapien 3. Patients with PS are not eligible, and PR cases with a regurgitant fraction of 30% or greater on cardiac MRI are eligible. The patients with high-risk open heart surgery are the primary indication, especially those with the impaired exercise tolerance or RVEDV index greater than 160 and RVESV index greater than 80 and QRS with greater than 180. This is Japanese criteria. First, Harmony is subjected to fit analysis using CT data sent to the company in advance for every candidate case. 388 cases have been analyzed until the end of September, and the anatomical fit rate was 85%. Through various steps, Harmony was launched in Japan and delivered to each certified institution since this March. Then, Harmony has rapidly expanded, and more than 100 cases have been implanted in 18 institutions so far. Harmony TPV in Japan has expanded to 102 cases in this half a year, exceeding the 89 cases in the 2-year US-Japan clinical trial. Unfortunately, there was one case of early post-operative sudden death due to ventricular arrhythmia. However, the post-procedural success has been 100%. Remarkably, the patients were not limited to the older age, but are distributed from very younger age, 70 years old, to the elderly, 60s to 80s. From here, I would like to discuss the selection of TPVI according to the morphology of the right ventricular outflow tract. The postoperative RVOT can have a great variety of morphologies on each case, but since the early 2000s, 5 classifications have been reported by cardiac MRI and still used worldwide as a reference. Type 1 is a pyramidal, type 2 is straight, and type 3 is funnel, and type 4 is convex, and type 5 is hourglass. All of them have fundamental diagnosis of the tetralogy flow and related diseases, which include post-status of autologous tissue or patch augmentation, and only homografts as conduits. In general, type 1 pyramidal is considered unsuitable for TPVI, and type 2 and type 4 are suitable for self-expanding TPV, and type 1 and 3 with some stenosis are suitable for balloon expandable TPVI. The results of the melody valve, which has been followed by more than 10 years, were reported by Dr. Tom Jones in Circulation Intervention in SKY very recently. The gradient across the RVOT has remained low even the 10 years. and the permanent regurgitation has also been maintained well. On the other hand, valve-related dysfunction, including composite of the RVOD reoperation, catheter reintervention, and hemodynamic dysfunction of more than moderate PR or gradient more than 40, and overall 10-year freedom was 54%. To summarize the ID study in this US series, it is the longest follow-up data on TBVI with 10% of death, 21% of TBVI explant, and 45 any kinds of reintervention, and 46 any kinds of valve dysfunction, and 20% of valve-related infective endocarditis, which can count 2% per patient here over 10 years. Melody valve has made a bovine jugular vein, so they may have a similar outcome as contegra conduits. As shown in these tables, there are currently 4 types of self-expanding and 3 types of balloon-expandable TBVs in clinical use around the world. In Japan, Harmony and Sapien 3 are now available. Harmony comes in 2 sizes, 22 and 25, and is expected to provide 50% of fit, anatomical fit. Venus B, which may be applicable to larger RVTs that Harmony cannot cover, we are discussing the introduction along with the US in HBD for children activities, and we are also considering the introduction of POSTA, which seems to be fit the Japanese physique regarding the postoperative morphology. Considering the life events of each post-surgical patient, surgical reintervention has been the only option, and the burden and risk increase each successive open heart surgery. So the mainstream approach has been to delay the timing and reduce their frequency as much as possible. On the other hand, TBVI considered to be less invasive, and therefore the concept has shifted to early intervention to maintain satisfactory right heart function throughout the patient's life. This is the very early recent report on Harmony TPV25, which shows that the valve dysfunction due to distortion of the stent frame and tissue accumulation can occur at a relatively early stage. Of 600 cases in the US, 6 cases had such an event, and 4 cases were treated with a Sapien 3, and 2 cases were treated with Melody valve, with the valve-in-valve fashion. In this case series, they placed a 29 millimeter Sapien 3 inside a 25 housing of the Harmony to ensure the sufficient diameter. Although we don't have data on long-term valve-in-valve procedure, it suggests that the establishment of a sustainable treatment strategy in the future. And this is a report based on the survey of multiple institutions performing TPVI. Following TPVI, 76% of respondents use only aspirin, and the remainders prescribe a second antithrombotic agent at discharge. And regarding the second agent, the most common was the aspirin, and next common was the clopidogrel, and followed by the warfarin and DOAC. Regarding the thromboprophylaxis for 4 positions of the transcatheter heart valves, after TAVI, DEPT is generally recommended in the early stage of the implantation and followed by the SEPT. And the same regimen is often applied for after TPVI. However, I don't think that it is established at all after the TMVI and TTVI. And in my personal opinion, because of the systemic vein or right heart is more susceptible to fibrin thrombus or red thrombus, DOAC may be preferable than antiplatelet therapy such as aspirin. In summary of my opinion, TPVI is considered to be less invasive, and therefore concept has shifted to earlier intervention to maintain the right heart function throughout the patient's life. The long-term outcome is not clear at this moment. However, we expect a sustainable repeated reintervention with the TPVI in TPVI fashion. TPV definitely requires an antiplatelet therapy, but no one knows the best remedy. And finally, if the patient is a young lady, we should have some discussion on each patient which will be better to recommend a pregnancy before the TPVI with no medication or after TPVI while preserving the RV function. 감사합니다.